to the second installment of the Addressing Barriers to Health and Safety webinar series. And the webinar series is looking at the intersections of the root causes of violence and is brought to you by the Pathways Statewide Steering Committee. Today we are really lucky to have Dr. Stephen Bezruchka here to share the work that he has been doing looking at health inequities. So thank you, Dr. Bezruchka, for taking the time to speak with us today. I'm going to go ahead and just hand it over to you to further introduce yourself and share what you've been working on.
Okay. Thank you very much, Cami, and I appreciate the opportunity to speak to such a wide, diverse range of people around the state and elsewhere. I've been working, just a little bit about me, I've worked clinically as an emergency doctor for 35 years, and I've also worked overseas. And in the last 20 years, I've sort of devoted most of my work to trying to understand the health status of the United States in comparison to other countries and the reasons why. So I hope to talk to you about violence, since that's most of the things, most of what you're interested in here. And I want to talk about intersectionality in a slightly different way than most people think about it. I think violence is a result of the intersection of social, political, and economic structures. And at the end, you'll see my email. I'm happy to engage in discussion with this. So I'm going to start out by asking how healthy is the United States? How well do we do in health outcomes? How well do we do in violence? Particularize it to what we know about Alaska, and then try to look at causes for the violence, beginning from preconception to birth and then beyond birth. And that's a tough job to cover all this in less than an hour. And I want to start by trying to situate our health status in this country. So, there's lots of data around and to make comparisons. And so I want you to ask this question. If you're a 15-year-old girl in the United States, what are your chances of dying before reaching the age 60? Compared with a similarly aged girl in Sri Lanka. I could try and ask you to show something in the chat room, but just pause and think, which girl has a better chance of being alive at age 60, the American girl or the Sri Lankan girl? And, obviously this is a trick question because I wouldn't have asked it unless the results were as you see depicted in this chart. That is, here we look at percent chance of mortality for a 15-year-old before reaching the age of 60, plotted from 1970 to 2010. And these data are actually taken from a Lancet paper, and you can look up this on our Institute for Health Metrics and Evaluation website. And you can see that back in 1970, the Sri Lankan girl had a 23% greater chance of dying than the American girl. But the curve crossed, and now the Sri Lankan girl has the health advantage. And we might consider why. And I can't give you an easy answer, but I will say that the status of women in Sri Lanka, I think, is better than the status of women in the United States. The first country to have an elected female head of state was Sri Lanka in 1960, and we still haven't had an elected woman to lead the country. I might mention one other thing. In Sri Lanka, close to 80% of all mothers breastfeed exclusively for the first 6 months. The United States figure has been rising, and it's about 16, 17, 18% right now, according to the CDC. So we don't do as well in mortality outcomes for adult mortality compared to a poor country. 40% of people in Sri Lanka live on $2 a day or less. Another quiz. Is the length of life for women declining in a substantial portion of U.S. counties over the last 20-plus years? This is, just think, is health for women declining substantially in this country? And again, these data you can find on the web. This is the a graph of U.S. county. Now you'll see Alaska is painted in one color because you don't have counties, and so the mortality data are harder to display. But what you see is, the solid red is where life expectancy, length of life, is declining from 1987 to 2007. And you see in about 30% of counties for women, we're seeing a decline, and just a handful of counties for men. And that's typical of much of the mortality data. Men are doing okay, not great, but women are seeing health declines. And I could present more data, but that's not a good picture. Let's now look at adolescent mortality. And adolescence is, I'm going to define as age 10 to 24. And how do we rank for deaths in adolescence? So here's a graph of mortality in that age group per 100,000 in 2009 from of just the rich countries. And you can see we have the highest rates of deaths for adolescents of all the rich countries presented here. And if you look at the leading cause, so you can see in the graph the causes, traffic crashes. You know, we lead the world. Of course, violence, we have, you know, the dark blue bar is way ahead of all the others. And that's a key figure that plays into what happens to youth in this country, namely violent outcomes. So if you ask the question, violence by ages of the perpetrators, this is a graph of homicide rates among youth, here defined as 10 to 29, by country per 100,000. And you see again, our young people are the perpetrators of violence in vastly higher rates than the other countries. And this is really an important issue. Why are our youth committing violence? Homicides we're talking about here. It's only when you look at the data among countries that you see this picture. I coined the term Health Olympics about 15 years ago. If health were an Olympic event, and you take almost any health measure, we wouldn't be there for the final day's race. Typically, we rack up the most medals in the Olympics, or the second most, as we did at Sochi last year. So if health were an Olympic event, and health measured by life expectancy, ponder where we stand among countries. And let me offer as a data source, the United Nations Human Development Report, and let's take the 2013 data published last year. Where do you think, if we go to table 1 and rank the countries from the healthiest, longest lived, that is, to the shortest, where is the United States going to be? And here we are with the data plotted. We're 35th. That is, 34 countries have longer lives than we do. And back in the this is 2013. When I went to medical school in 1970, we were 17th. When I went to public health school in 1992, we were 22nd. And although our health keeps improving, other countries see faster improvement, so they have longer lives. And so so why? Well, the typical answer I get from audiences is, well, you know, we smoke too much, or we eat too much. It's diet and these bad behaviors. And if you reflect on this graph, which is the country with the lowest proportion of men smoking? Smoking is obviously bad behavior. The country with the smallest proportion of men smoking actually is Sweden and the United States. About 20% or so of American men smoke. The country with the highest proportion of men smoking happens to be Japan, the longest lived country. Obviously, that's not the reason Japan's so healthy, but it does suggest that there are factors other than personal behaviors that produce health in societies that we don't address in this country. We're all focused on individual personal behaviors. So this is, you know, we turn out to be rather good at dying young. And the Institute of Medicine came out with a report now published 2 years ago, U.S. Health in International Perspective, Shorter Lives, Poorer Health. You know, it's a 400-page tome. You can basically find all the material that I'm talking about in this report. And the Institute of Medicine is our highest functioning think tank on matters of health and medical care. And And they point out on page 3, the quote that I have there, Americans who do all the right things, white, insured, college educated, make lots of money, we have worse health than those than similar groups in comparison countries. And they present the data there. I teach about this. That says that by doing personal things and being successful and rich and all that, we still die younger. We have shorter lives. This is a chilling thought, and it should be it should be something that we want to change. But so far, that's not happening. So what about Alaska? Well, there's good news and bad news. So, there's this United Health Foundation publishes rankings on a variety of indicators by all the states. And this is the most recent data. And they aggregate a whole bunch of data and produce an overall rank. And Alaska's sort of in the middle, overall rank 26. And on some things they do quite well, and I'll highlight some of those. And on some things, Alaskans don't do quite so well. So if we look at the good outcomes, very low percentage of low birth weight in this in your state, and that's the lowest percentage in the entire country. And low birth weight is an index of development of the fetus in the womb, and higher birth weights in general tend to have better health and fewer chronic diseases as they age. Similarly, for infant mortality rate, it's kind of an amazing thing. Alaska's infant mortality rate ranks second in the country. So really, you're doing well in the beginning of life. But where do things crop up? Well, among violent crime, again, that's from the United Health Foundation report, you are second from the bottom, ranking 48 out of 50 states. Another indicator, binge drinking. Again, lots of binge drinking. Now, you probably are aware of these issues more than I am, since I've only been up to Alaska a few times, and it's mostly to talk, and it's not to see the situation on the ground. So I'd be interested in your perspective there. So if we look at homicide, this is age-adjusted homicide rate for all Alaskans, Alaska Natives, and Americans from 2000 to 2010. And the round blue circle are the Alaska Natives, and you can see they're sort of going up and down, but above the American, the rate for the whole country, and higher than the rate for all Alaskans. And this is what you see on the ground in Alaska. Unintentional injury, a slightly different classification than homicide, same picture. High rates for Alaska Natives. All Alaskans are above the U.S. rate there. One final thing is child maltreatment. And these are difficult. These are reports. And so, homicides are easy to track because we tend to know when everybody's born and die. Maltreatment is harder, but nevertheless, this shows there's a lot of child maltreatment in Alaska. So what's going on? Well, I think if you were to read one source, it would be this book by Richard Wilkinson and Kate Pickett about the nature of inequality in society and how that affects health. And it's got the title The Spirit Level. It was published in 2010. It sold several 100,000 copies already. It is a popular book in Europe and essentially unknown in this country, but in 25 languages. What is their key argument? What they do is take z-scores of data among rich countries, and the z-scores are basically a unitless way of looking at life expectancy, infant mortality, school outcomes, homicides, imprisonment, teenage births, trust, obesity. They've taken all these z-scores among the countries listed there, and they've multiplied them together to get an aggregate index of health and social problems. And rather than put a whole bunch of units on the X and Y axes, they've removed the units. they describe all the data in the book, but from better to worse, and they've graphed it against income inequality, and a uniform measure across these countries of the differences between the rich and the poor. And again, the data are there, but they've just made it easier to read by graphing them between low and high. So if you follow U.S. outcomes for a lot of these things, and you look at what other countries are doing, you find we don't score well. I mean, we don't live long. Our infant mortality is higher than all the other rich countries, highest rates of teen births, homicides I've already pointed out. And so we actually, I've circled the USA up in the upper right. We have remarkably poor outcomes for most of the things that we value in this country if the standard is comparing ourselves with other countries. This is something that if you dig into the data, I'd love to hear somebody who says this isn't true. When I speak, I tell people, don't believe a word I say. If you think this is important, figure it out for yourself. And so I'm asking you to do that if you don't think that this is, I'm painting a correct picture. Let's look at homicide, since this is really about violence. And this is an interesting graph of the age of the perpetrator of violence. Okay, so we're looking at men in England and Wales, that's the dark blue, with men in Chicago, that's the purplish pink color. And on the x-axis is age in 5-year intervals. And you can see that the homicides are committed by roughly, most of them are between ages 10 and 40 or 45. That's men. The women, they hardly, they don't kill that much, and there's not much difference throughout the lifespan. So on the left, so this is England and Wales and Chicago. The age of the perpetrators of the violence of homicide per million people. Curves look the same. What's the difference? The rates. The rates you see on the right is the Chicago rate, 30 times the England and Wales rate. And so we have we've cornered the market on violence in this country, and that's you see this in Alaska, you see it in Chicago, you find it all around. Why? Well, violence turns out to be related to the gap between the rich and the poor. You saw in the Wilkinson and Pickett material that the gap between the rich and the poor appears to be really related to all the indices of health and social well-being. So let's look at that. So these are data on homicide rates with the same income inequality measure. And not unsurprisingly, when you graph them, you see we're an outlier. That is, we have a lot of homicides. Yes, they're related to our high income inequality, but there's even we're even above the curve substantially. That has to do with the availability of the weapons to allow this to happen. You can break these data down by state. Alaska is pretty remarkable in having relatively low income inequality. Part of that, I think, is the Alaska Permanent Fund effects and a whole bunch of other issues. But Alaska has, as you see, very high homicides up there on the y-axis. Only a few states have more, and we saw that from the other data I presented. So what is it about egalitarian versus hierarchical societies that might pattern all of these indices that I mentioned about health and social well-being and violence? Think about an egalitarian society, one with a small gap between the rich and the poor, and consider the relationships in that society. By and large, they tend to be those of respect, equality, friendship, support, cooperation, community, sociability. That's from a psychobabble perspective. Those are nice, healthy sounding words. Consider the relationship in an unequal, hierarchical society, where the power relationships are those on top have power, they dominate, they coerce. Those of us below them submit, resign ourselves to our fate. resent, but we don't focus, we don't voice our resentment. We feel humiliated and shamed. And shame, I think, is the ultimate emotion or feeling in a hierarchical society. And so you live in a culture of inequality, and you face a lot of stress. So how does that really directly relate to violence? If you were to read one book on it, I would read James Gilligan's book, trying to understand why we're so violent in this society. And he's a professor of psychiatry at Harvard, and he worked as a Massachusetts prison psychiatrist for 25 years. And he writes in the book that he never saw a serious case of violence that wasn't based on somebody being shamed or disrespected and trying to redress that. I think that's what we have to understand, that violence is not an individual behavior, it's a response to something going on in society. Well, this is youth homicide rates by county throughout the country, and you can see that in the lower left, they have broken it out for Alaska, and you can see where a lot of the youth homicides happen, and you face this in your daily work. So there's something going on in Alaska, and that's consistent with the previous data. Domestic violence is another thing that you see, and rates of, again, it's hard. You know, a death is a death, and you can measure those much more accurately than reports of domestic violence. But these are WHO data on intimate partner violence as reported in 2010. And we don't lead the world there. I think if you look at South Asia and Africa, there appears to be more intimate partner violence. So why is that? Well, a key concept in understanding conditions are the conditions in early life really last a lifetime. Healthier societies are those that privilege early life in a variety of different ways. And actually studies, cohort studies suggest that somewhere around half of our health is programmed in the first few years of life after conception. A student of mine came up with this graphic for an Ignite talk here in Seattle of the first 1,000 days. You know, by the time you get to blowing out your 2 candles on your 2nd birthday, roughly half of your health as adults has already been programmed. Key thing that isn't in this graphic is the intergenerational transfer of health. That is, as we go from the erection to the resurrection, or from the womb to the tomb, or conception to death, there are factors, the latent factors that affect you in early life that you can't change later in life by fixing something. There are pathway factors and cumulative factors, and this takes place in society, and there's a feedback loop. So that and one way to understand this is to recognize that all of you listening and watching this started life in your maternal grandmother's womb. That is, the ovum that begat you, your mother made inside your maternal grandmother. So your maternal grandmother's conditions have to affect your health, and we can demonstrate that with studies. And by and large, to recognize that there's intergenerational transmission of health factors, of behaviors. You know, yesterday I talked to a class at the Western Washington University up in Bellingham, and I talked about epigenetics as the means by which factors that impact our lives get passed on scientifically. So a key thing is the recent awareness of adverse childhood experiences and how this impacts adult health. And this particular chapter by Vincent Felitti and Robert Anda, I think, is the best summary I know of on this. Basically what they did, or what Felitti did when they started their studies, was to look at people in Kaiser Permanente, San Diego. These are all middle-class people who are in this health maintenance program, and they were looking at weight loss efforts, and they found that those who seemed to be the biggest losers, lost the most weight, were the ones who dropped out of the programs the most. And then they tried to explore that, and they realized that there was a lot of abuse in early life that seemed to be related to this. So they then enrolled everybody in the Kaiser system and began asking about abuse and household dysfunction and neglect in early life. And I'll just show you a few of the kinds of things that demonstrated. All this may be very apparent to you, but let me at least present emotional, physical, and sexual abuse. In the Kaiser population, you can see the numbers there as to how common it was. Often we don't think of household dysfunction affecting us, but if there's domestic violence, if there's alcoholism, injection drug use, if somebody's in jail. 1 in 100 American adults is in jail in this country, and that's the highest rate around the world. And I found this in the emergency as an emergency doctor, that being in jail or having a family member in jail was really a difficult situation to deal with. Also, people with substantial mental illness, and also not being raised by your biological parents. So they found that household dysfunction was an important adverse childhood experience, and similarly, emotional and physical neglect. So in their studies, and these are, these cluster. That is, they have an ACE score. The more of these you have, the higher your ACE score. And in their studies, 5% of adults have 6 or more ACEs, and so these are cumulative and add up to a whole host of worse outcomes. This is sort of their model as you go from conception to death. Adverse childhood experiences then produce all these impairments. Basically, here we are obsessed with trying to improve our schooling, so we do better on international comparison tests. But I offer that because of the problems in early life, the kids that go to school aren't really able to learn the way that kids who don't have these adverse childhood experiences do. And if you have these adverse experiences, you then develop a lot of bad risk behaviors. As an ER doc, I used to blame all my patients for smoking and drinking and shooting up and causing me all this grief in the ER. But I came to see that they took up these behaviors to try and help them to cope with life as it is. And so I came to blame myself for creating the situation in which that was how they coped. This leads to most of the chronic illnesses that we now suffer in this society, and social problems and an early death. The Felitti Kaiser group weren't the only ones looking at this. So this is a paper by James Heckman, who's a Nobel Prize-winning economist, and I'll say a couple of words about him later, showing the more ACE scores you have, the more likely you are to smoke, try suicide, inject drugs, have a sexually transmitted disease, or be obese. The more of these things, these ACEs accumulate, the more the behaviors you engage in are just ways of trying to cope. What is missing from the ACE studies so far is that they control for socioeconomic status. But now we're beginning to unpack socioeconomic status, and it's probably not surprising to learn that if we address the question, who has more ACEs, rich or poor, then the answer is poor. And this is a study from Pierce County that's in my backyard, Tacoma, south of Seattle. And here those adults reporting poor or fair health by ACE scores. You can see a clear distinction even with the confidence limits between those making more than $50,000 a year and those making less. So how does this happen? What's actually going on physiologically? Well, this has been looked at a lot, and children having a lot of ACEs have a smaller volume of their prefrontal cortex. That's the forebrain. It's our social organ. They're not able to relate to other people as well as those who have more synapses in that area. They have poor executive functions. When these children grow up to be adults, their forebrains continue to be smaller, and so less capable of engaging in society the way that we're designed to. Behaviors, young kids with a lot of ACEs have symptoms of ADHD, poor attention, hyperactive, can't regulate their emotions, and so on. And as adults, they become depressed, have post-traumatic stress disorder, and substance abuse. Now, I'm not saying that you can't survive a number of ACEs and do well. I mean, people do that. These factors of resilience that are not so well understood. But these are looking at distributions, suggesting that the more ACEs you have, the harder it is to do well in life and be healthy. And you see this in a variety of other physiologic issues. Children with a lot of ACEs have higher cortisol levels, and if the cortisol being a measure of stress, chronic stress, and given a stressful encounter, they can't raise their cortisol levels to sort of deal with the big one. And similarly, with the adults, they have higher corticotropin-releasing hormone levels, again suggesting a hypophyseal pituitary adrenal axis. That's what HPA stands for. That system doesn't function as well. We measure a whole host of biomarkers in the immune system, and they have elevated inflammatory markers as children. They have these as adults. When you challenge them with a herpes infection, they can't mount an immunity to it. And as adults, they become hypersensitive, have hypersensitivity in the immune response sense. And that's why we see a lot of multiple allergies among people. People are allergic to all sorts of stuff that I don't remember being so common 40, 50 years ago. And not unsurprisingly, this is a graph of ACE scores and how likely you are to be in a different age group. So if you have, if you have if you have an ACE score of 4, your chances of being older than 65 is pretty small. Whereas if you have no ACE scores, your chances of being in the older age group is higher. And this is just a way of addressing the mortality issues here, namely people with a lot of ACEs don't live that long. Is this related to income inequality? Well, the studies at U.S. county levels show this. In other words, the higher the income gap across U.S. counties, the more likely children are to be maltreated. And that's another way of looking at ACEs. So domestic violence, what are the outcomes that we see from domestic violence? Again, issues that you deal with all the time. Well, higher rates of maternal mortality. I didn't talk about maternal mortality, but the deaths of women of childbirth-related causes is actually increasing in the United States over the last 15 years. That is, we've seen a 50% increase in maternal mortality from 1995 to 2010. If you take that period of time, there are only 8 countries in the world that have seen an increase in deaths of women of childbirth-related causes. And we're one of those 8. The others are countries like Afghanistan, sub-Saharan African countries, where you can understand that, the kind of conditions there are not so good, so you could reasonably expect Afghanistan, El Salvador, you might be able to see that, moms are dying of childbirth-related causes. But this shouldn't happen in the richest, most powerful country in world history. Domestic violence results in increased infant mortality, low birth weight, preterm births. We have one of the highest rates of preterm births all around the world. Once the child is born, again, in a domestic violence, intimate partner violence situation, the child doesn't attach securely, and so they have a whole host of other problems. The term secure attachment was coined by John Bowlby many years ago, and we need a nurturing family environment to have secure attachment. lots of child mental health issues. We have, among all the comparative studies, the most mental illness of all countries studied, and now especially children, and they're being medicated in a lot of circumstances because of these issues. So what are we going to do about this? I love the title of Gar Alperowitz's book. What then must we do? Well, 100 years ago, Frederick Douglass said it's easier to build strong children than repair broken men. Very important African-American who saw these things. And of course, the Greeks have known about this 2,500 years ago. But we have a medical care system that is focused upon repairing broken men, broken women. This is the situation that we're in, and it appears to be very profitable to do that. We spent last year, the estimate is $3 trillion on medical care. And that's close to half of all the money spent worldwide, and we don't have the long lives or low mortality to show that, because we're not building strong children. I mentioned James Heckman, the third article on this report from Science last year, which says, if we focus on early life, we're going to boost adult health. All the studies there are remarkable in showing the consistency that if you raise healthy children, if you have the societal circumstances in which children can be healthy, then you're going to see tremendous gains in health later on. As an example of that, if we take how much countries spend on each year of life, you find Sweden, one of the healthiest countries in the world, spends more money on the first year of life than in any subsequent year. In the United States, where do we spend our money? Well, people my age and older people, we don't spend much money on early life, and I could show you graphs of these comparisons, but I just want to point out, we don't put our money where it really needs to matter in terms of being healthy. So what have I said? I want to leave some time for chat and discussion. Our health status, at best, is that of a middle-income country. That is, we're less healthy than all the other rich countries in mortality indicators, and I mentioned Sri Lanka as an example of a country that does better. But violence is a response to stress in our society. It's related to shaming. Remember, James Gilligan said he never saw a serious case of violence in which the perpetrator wasn't trying to redress being shamed or disrespected. And this happens in a society in which economic inequality shapes adverse early life. So we have to understand that early life, the conditions that society creates in which life begins, are there to plague us forever. And that we have to build strong children, then repair broken adults. So if you think of intersectionality, early life conditions discriminate. I mean, there's a few rich and wealthy people who can afford to raise children in good circumstances, but for most people, there's discrimination based on the stress of early life, and personal economic issues relate to oppression that is really patterned by the inequality in society, domination. So discrimination, oppression, and domination, I think, are the key intersections that are then transmitted across generations and suggest that once we start figuring out how to do the right things and put them into practice, because of the intergenerational transmission of health, it's going to take 20, 40 years for us to regain the health status compared to other countries that we had back in the 1950s. We tend to want to see things happen very quickly, and I don't think our improving our health status is going to follow that pattern. So Gilligan has another book, Preventing Violence, and I just want to, chapter 5 is on how to create less violent societies, and I just want to mention some of the key points there. We got to recognize that people shame other people because they're treated inferiorly. And in your Alaska Native situation, I would really be interested in how this plays out in what you see. So people shame other people and assign them to an inferior social and economic status on the population scale. You know, this isn't new. None of this stuff is new. George Bernard Shaw, the British playwright in 1927, wrote a book called The Intelligent Woman's Guide to Socialism and Capitalism. And he writes in there how the woman maintains her position on the social precipice by being by putting down the people below her and doing the bidding of those above her. So these ideas of hierarchy and putting down those below you and fawning those above you has been around with us for a long time, and it's especially the shame of those who are put down try to redress that, and some do it in violent ways. And Gilligan points out not everyone who is shamed will become violent, since people have independent sources of self-esteem and self-respect to withstand even fairly intense disrespect from others. But on a distributional level, the more shame in society, the more put-downs in society, the more inequality, the more people will become violent. And I think we're seeing this globally. I think the various terrorist ideas are really a response to what we did after September 11th, but that's a whole other issue, but it relates to this. So Gilligan says, prevent violence by not shaming and not depriving people of access to tools to maintain self-respect when they're disrespected by others. These are very utopian ideas, but I think that's sort of the key issue that we have to try and deal with. So violence doesn't occur spontaneously. It's only when we cause it. So we should stop causing it. And Gilligan suggests we derive benefits from our violence. Why are we the most violent of industrial societies? Why do we sell arms to all these poor countries? And why do we have almost one? We have the firearms are amazing. We have more automatic rifles in the civilian population than we have in the Army. And this is a big part of our economy. That violence occurs because most of the benefits go to our extremely wealthy or ruling class. And one of the legacies of the Occupy movement is now when you talk about the 1% and the 99%, most people know what you mean. We've got to do something about that. And the cost of all this, it's cheaper to build strong children. We could provide basic education and healthcare all around the world for not that much money. But he says what we need to do is to start reducing economic inequities. Simple thing, very hard to do, and I'd be interested in your thoughts on how to do this. So I looked at your website, and I tried to see about intersecting identities and root causes of violence, and all I found was that page no longer exists. So I hope you can beef up your website and try and look at these upstream issues that are really the root causes of violence. And I think it has to do with the inequality in our society that produces this shame and disrespect, and there's going to be a certain segment of that society that tries to redress that in these violent ways. So this is my email. This is the Population Health Forum's website at the University of Washington. I'd be happy to engage you in discussion about this, and I hope some of you have been stimulated to share some of your ideas in the chat box, and I think we have 10 or so or more minutes to do that. I've been sort of in a monologue here, and I don't know if anybody's out there.
So again, if folks have questions, feel free to put them in the chat box or any comments.
perhaps I can ask you if there's anything you'd, you know, if these ideas resonate in Kodiak or Sitka or Nome or Unalaska. I mean, you're on the ground there and you see this. Does any of this make sense to you? Shame occurs within groups and not between groups. I think both things happen, actually. That is, we have a lot of gangs, and there are clashes between gangs, but also within the group, especially with the advent of social media. You know, if you think about it, people are trying to portray themselves in social media as being successful and beautiful and desirable, and that's a way of putting down others. And so, you know, I don't think we have a good sense yet of how social media is doing that. But I think we have shame within groups and between groups. We all want to be liked and respected. You know, that's what we crave. And how do we do that? So I'm just going to read some of these. Sorry, it looks like the U.S. has dramatically more violence than other countries. Is the income inequality is dramatically more severe than in the other places? So yes, you know, how are we going to look at, how can we get some sense of inequality in this country? Well, if you take 2013, the highest paid person made $400,000 an hour, and the minimum wage in Washington State in 2013 was $9.16 an hour. So inequality is huge in this country. Now, our violence rates are the highest among the rich countries, but not in the world. And if you go down to Central America, to places like Honduras, you know, whereas we have homicide rates in the 10 to 20s, theirs are in the 90s to 100. And that's a, you know, that's a social justice and inequality phenomenon, but we can't do the same comparisons that we do here. I'm going back to this. Sorry, I'm just, what other factors do you think are driving this? Well, I think it is the level of poverty in this country. Now, Alaska, in a sense, has, well, your poverty is kind of different, I think, than elsewhere, but if you compare our poverty levels in this country compared to other countries, you know, somewhere between 20 and 25% of people are below the poverty line in this country. Among children, you know, UNICEF does all of these league tables on various indicators, and the United States has more child poverty than any other rich country except Romania. In their UNICEF report, Romania has slightly more child poverty than the United States. And this is because we have an individualistic mentality in this country. We sort of believe that the poor brought it upon themselves, and if they'd only worked hard and you know, they could pull themselves up by their bootstraps. But because of the early life compromises, they can't. You know, healthier societies aren't so individualistic. How do we get buy-in from the wider society to prevent violence? So what I do in my courses that I teach here at the University of Washington is I present this information, and then what the students have to do is to create a community event and present the information there. In other words, they have to take the ideas out of the classroom and present it to others, because most Americans don't realize that we're dead first. I mean, that's preposterous. You know, most people are just shocked by these ideas. But when the Institute of Medicine says shorter lives, I mean, they don't say that just on a whim. So I think we need to gain facility in talking about these ideas by whatever sort of choice of language and ideas that we do. You know, I've talked to grade 8 classes, grade 7 classes on this material, and I've talked to homeless seniors about this material. And I try to get every chance I can to develop speaking points to do this. And I would urge you to try and do that in whatever circumstances you have access to. Yesterday up in Bellingham at Western Washington University, there was somebody there from the local health department, and you know, she's very good at getting out into communities and trying to talk about these ideas. I'm trying to work through these.
Stephen, I moved one that was just asked to the bottom, so hopefully it's right in front of you.
Okay. How do we get, this is a very important point, how do we get these groups to work together and recognize their dependency and intersection? You know, there's no, none of these ideas have sort of easy answers. I was talking yesterday about, you know, I came to realize that the health, in talking with this, the health department, how, you know, we have 39 counties in this state, and the health departments all work more or less independently of one another. And how do you get beyond that? You know, I sort of do what I can. Namely, I teach, write, and talk. I think there's more awareness of these ideas than there has ever been. I think we are in the midst of a social movement. You know, as a child of the 1960s, there was a social movement going on, a social revolution in a sense in this country. And while you're in the midst of it, you're not aware of it. So it's quite complex. I mean, social media offers us a tremendous opportunity. More and more people are feeling that something's not right in this country. We have the opportunity to talk about the difference between the 1% and the 99%. And if we can find ways of presenting the health impacts of that, of presenting the importance of early life, you know, just the speaking point of you all began life in your maternal grandmother's womb, because that's where the ovum that begat you was made. You know, people, you know, might think about that and start thinking, gee, maybe we need to change how we address early childhood, early life. Yeah, happy to make any of this material available. The presentation, I can send you the presentation if people want that. Yes, the point about I've had former students who worked in Bethel, for example, describe the circumstances there, and you're right, it is very much third world like. But well, Alaska has better outcomes than you know, some of the lower 48 states, and that has something to do, I think. You know, you have something going for you. You have the Alaska Permanent Fund, which is a guaranteed income for all Alaskans. You have the, you know, you have all these resources there, and you've had some settlements that I think have enhanced the respect of the native people there. That, you know, I mean, the worst health outcomes in the country are in Pine Ridge Indian Reservation down in South Dakota, and that's, you know, the Indian reservations in the lower 48 do not appear to be as badly off as sorry, are worse off than those in Alaska. But the violence is real high up in Alaska, and that, I think, has to do with intergenerational transmission. You know, if the parents were, if their parents were violent with them, they'll be violent with their kids. Their kids will try to play out that violence because that's what they know. I think the media aren't a help either. You know, the amount of violence displayed in American television and movies is huge. And unfortunately, we see that as kind of normal. You know, I would have to see people in the ER who were in these big fights and stuff, and they'd come in all broken. And that wasn't the way it was portrayed in the movies. You know, it seems to be our way of trying to beat up on the other person that because they've been disrespected. The gold rush coming up to Nome, and yeah. So let me just say this: we're talking about the drugs have to do with cocaine, marijuana, prescription drugs. As somebody who worked in inner city ERs and also worked in an ER near where the richest person in the world lives, Bill Gates, you know, when I worked in Tacoma, I saw, you know, cocaine, chest pain, heroin overdoses were sort of bread and butter. And when I worked near, you know, in the ER in the hospital right by where all the wealthy live, I never saw that. And so I came to see that people using all of these substances were really a way for them trying to cope. And studies in monkey models, for example, let me just mention this. If you take cynomolgus monkeys and you house them in a compound, and they will set themselves up as in a hierarchy, alpha male, beta, gamma, delta, epsilon, you know, the alpha male being the highest. And in these studies with these cynomolgus monkeys, after they've observed the hierarchy for a couple of years, they put a femoral catheter into the femoral vein and hook it up to a cocaine pump. And then they look at who uses the cocaine. And what they find is the alpha male might push the lever once or twice, doesn't use. But the ones on the bottom can't push the lever enough because they're getting put down by all the higher ranking monkeys, and they're trying to cope. And one way to do it is with the drugs of abuse. Gabor Mate, a doctor in Vancouver, British Columbia's Lower East Side, who works with these people there, says, you know, it's related to the early life circumstances. And I think the evidence is pretty clear. Yeah, synthetic drugs, yeah. Anything else? What other things would could I at least venture my opinion or observations on? Or maybe, you know, listening for an hour is enough. You know, with you in the trenches, what you need to do is start talking about it. I mean, finding ways of presenting our health status as that of not a rich country, of trying to show that inequality in society actually produces biological changes in humans, and it does it early in life. There's a tremendous amount of science behind all this. I'm sort of not, I don't present stuff that I can't find many, you know, references for, that I sort of evaluate. The science is very strong. What can okay, so what is the single most effective way a primary care provider can demonstrate trauma-informed care in practice? This is a very important point. You know, we think about cultural competency, but we don't think about, we think about cultural competency, but not structural competency. Can we point out to our patients, well, can we recognize that being poor is the biggest risk factor in anyone's health? Being poor as a child, being poor as an infant. Now, the word poor, I think we have to sort of explore in a different sense in a lot of Alaska Native communities, because they may not have a lot. Well, I grew up in a working class neighborhood, and everybody else was working class, and this was the 1950s when we didn't have lifestyles of the rich and famous. Then I went away to university, and I realized, you know, I'd grown up in a poor neighborhood. But today, everybody knows where they stand because of all the media influences in this. So trying to present, so trauma-informed care would be to recognize that this person's situation is really a result of what's happened in society. Most of it is not their fault. That's not to say that none of it's their fault, but respecting people for coping with the circumstances that are in their living situation is, I think, an important thing to do. It took me a long time to get to there as an ER doc. I started out blaming all my patients for all the grief they caused me in the ER. But once I realized, but it was a slow process to come to realize that the problems were structural. Is there an existing statewide or national structured competency initiatives? Where was I? That you're aware of, structural competency. Let me post this paper on structural competency, or let me send it to Cami. Being poor wasn't so bad. We depended on subsistence. Yes, no. It's if you think about hunter-gatherer societies, that is where people foraged and hunted, which is what you see in some respects still in Alaska. If everybody has enough of the basics to satisfy life, if everyone is poor, then no one is. That was the value mentioned by Marshall Salins in his Stone Age economics book. He said if everybody's poor, then no one is. Poverty is an invention of modern society, and it's grown with society. And how to get back to the values of caring and sharing is the challenge. That's why a lot of Native groups want to regain their abilities to be to live a subsistence lifestyle. That was the original. That was the original leisure time society. Another quote from Marshall Salins in Stone Age economics. The people in their simple environments where they lived, where food was accessible and easy to get at, was really, they were really, didn't take a lot to get enough to eat. I've read a lot about the Inuit in northern Canada to realize that they're, and you see this in Alaska too, until we come along and destroy or change their environment, things are we're really pretty good. And I see this, I lived in Nepal for 12 years, and I lived among, what you would characterize as some of the poorest people in the world, but until you get close to the road and development, they don't think of themselves as poor. So do you find that the neurospeak approach is useful at changing minds? Like a lot of neural hype. Okay, so it depends on the audience. Like if I'm speaking to homeless seniors, I don't talk neural hype. It was kind of, I talked about the political situation. I remember quite vividly with this one particular group when I said, when did homelessness first occur in the United States? One guy over here said Reagan, and everybody else chimed in, yeah. And so we could address, well, what was it that President Reagan did that produced homelessness? And they knew it was cutting low-cost housing support and mental health services support. And then they were on the street. So I think our challenge is not is to limit the neurohype and talk in ways that people that people will relate to. If I'm talking to a group of people and I want to engage them in thinking that I can relate to important issues, I might say, for example, suppose I was standing up here wearing sunglasses. Would you take seriously anything I sort of said? And then I say, well, who is the only primate? Who's the only ape or monkey-like species with white sclerae, whites in our eyes? And so, that's an interesting discussion with people because most of us don't think that our eye really say so much about us, but I bet all of you listening, if you closed your eyes, could see the eyes of your mother there. And so eye contact is incredibly important, and we need to sort of foster that. We have white sclerosis for a reason. It has more to do with early life than it does in older people, but that's another sort of engaging topic.
Great. Well, I want to be mindful of time, so if folks have further questions for Dr. Bezruchka, please feel free to follow up via email with him. And yeah, if you want to send me that paper and stuff, I can send it out to folks who were able to call in today.
Yes, yes. I want to thank you all for listening and paying attention. And as I said, I'd be happy to engage with you on other issues. And thanks for your attention. And thanks to Cami and the organizers.
Yeah, and thank you for joining us and sharing about your work. We appreciate it. And just to let folks know again that we are recording this, and it will be up on the ANDVSA website along with all of the prior barriers to health and safety webinars that were done in the first installment. So thank you all.